So this is a clinical pathology of ocular tuberculosis. I should not have given the title, and it's a very interesting case. This is a 26-year-old female, history of swelling in the left eye on the conjunctiva, 1.5 months. Marked dimness of vision in the left eye for 7 days. Very acute. Referred by local ophthalmologist, he thought that it is a squamous cell carcinoma of the conjunctiva. And this is the vision 20/20 in the right eye. Left eye has got light perception and projection. Slit lamp examinations, right eye normal, left eye multiple KPs were there, and large mass lesion over the superior limbus and multiple small lesions on the temporal side, fundus normal. And they look at the picture, and you won't see this type of pictures very often. A kind of a mass lesion, superior globular lesion. What could be the diagnosis? This title already been given, but it was a challenge to the diagnosis that point of time. And there is a inferiorly, and particularly in the temporal part, there was a kind of a lesions were there that very closely mimics squamous cell carcinoma or conjunctival dysplasia. So this was a diagnosis was made even by us as a squamous cell carcinoma of the conjunctiva. So we didn't have the UVM and all, or ultra ASOCT. So patient's history was quite remarkable, interesting. History of blood transfusion 1996. He developed pulmonary TB 2002, treated with anti-TB drugs, 4 drugs. She get pregnant in January 2003, developed herpes zoster skin lesion, maybe an opportunistic infection due to the HIV. He was diagnosed to have HIV infection July 2003, was put on Girovidin 300 mg twice daily, August 2033, developed swelling in the conjunctiva September 2003. So all the episodes of HIV infection, after that he developed conjunctival mass lesion. ELISA for HIV was positive. CD4 count was not bad. CD8 count is 562 cells per cubic millimeter. Total WC count 5,700, and platelet count is normal. ESR was remarkably raised, 125 millimeter first hour. And if you look at the chest X-ray, that time CT scan was not that vogue. This is our. So this is superior mediastinal widening was there. There's no parenchymal lesion. And then this is July 2003, repeat chest X-ray shows superior mediastinal staining. We did the CT scan of the orbit. So particularly to see the extension of the mass lesion, and no evidence of intraocular extension was seen. This is a CT scan picture. CT scan pictures showing that lesion, and there is no extension in the inside. So it's a superficial. Enlarged preauricular and submandibular lymph node was seen, and this could be due to squamous cell carcinoma that can produce preauricular and submandibular lymph node. Now what is your diagnosis? Diagnosis is obviously known. At the beginning I told you, we did a conjunctival mass excision and a local anesthesia, and the sclera found to be deficient below the mass lesion. And the scleral patch graft was done. Leukoplakic lesion, which was inferiorly and the temporally, was also excised. And this is the histopathology picture. You can see a bit of epithelium, which is, I don't have pointer here. This is a bit of epithelium was there, which is a little disorganized, and in the stroma, you can see a granuloma, big granuloma. There is a giant cell and lot of lymphocytes and few epithelioid cells. So this from a granuloma, there is no caseation seen in this slide, but if you next slide, if you see the multiple giant cells. And what is very interesting is pathognomic was there under this slide. You can see there are a lot of caseation necrosis and then giant cell formation. This is so classic for tuberculosis. We went ahead and did a special stain, that also no surprise, that also picked up acid fast bacilli. on Gill-Nelson stain. So this was the patch graft, and specimen one, we go ahead, and as we did have PCR facility, we did the paraffin section PCR. MTB DNA was positive and nested primer which detects MPB64 gene. And you can see the blue arrow showing the MPB64 gene. And then surprisingly, that's the small squamous cell kind of lesions, epithelial lesions temporarily was also positive for MPB64. So it was histopathologic, molecular biologic study, special stain, all indicated that there is a conjunctival tuberculosis or conjunctival tuberculoma, to be very specific. And the patient did well. I followed up the patient, called him and brought him over there, and it was surprisingly these things once excised and the mass is removed. Patient was symptomatically better, and that conjunctival patch graft was nicely taken. So ocular lesion, coming back to the discussion part of it, ocular lesion due to the TB in HIV positive patients, I've seen many of them mainly involve the posterior segment. They have got tuberculoma of the eye or subretinal abscess. And here is a case where we found that there is a conjunctival tuberculoma. I didn't put as a single case. I have made 100 case of an AIDS past 100 cases that I included. So otherwise it made it as a separate publication also. And that was the HIV in 100 consecutive cases. There the photograph of this case with the micro photograph is available in, this was in American Journal of Ophthalmology 2000. So thank you very much.